So today we have Dan Mullarkey with us. He is the medical director at Skin Analytics, and they work extensively with NHS to improve diagnosis of skin cancer analysis using AI. Dan, it would be great if you could share a bit more about Skin Analytics and yourself before we get started with our questions for today.
Great. Well, so thank you very much for having me on. I'm Dan Mullarkey. I'm an NHS GP by background and still practice in a GP practice in London. But for the past nearly 10 years, I've been working within health technology on the innovator side, bringing AI as a medical device to pathways within the NHS, and most recently, since 2020, working here at Skin Analytics. So we've developed the first class 3 AI as a medical device. So it's a CE certified medical device that is being used within NHS skin cancer pathways up and down the country, supporting the earlier identification of skin lesions where there's a concern of skin cancer, giving patients that earlier reassurance if it is fortunately a benign condition, and allowing that expert capacity, that dermatologist capacity, to focus on those patients who need it most.
Okay, thanks a lot, Dan, for that introduction. So our first question for today is, of all the medical challenges available, why did Skin Analytics choose to focus specifically on skin cancer rather than any other health issue?
So I think there are a couple of elements to this. I think the first one is we know that skin cancer is the largest cancer referring specialty in England. So the NHS data sort of supports that this is a big volume, and it's a referral pathway that's increased by 10% year on year for the best part of a decade. At the other end of those referral pathways, we know that there just aren't enough consultant dermatologists. So the suggestions are sort of as many as 1 in 4 consultant dermatologist posts are unfilled. And so you have this massive mismatch between demand and the capacity that's available. So we wanted to come into a pathway where we can actually have a real impact. And quite early on, we decided that actually the impact that we want to have is creating the technologies and the tools in the appropriately regulated way to be able to give a meaningful additional capacity to a pathway, not by just upskilling or giving decision support technologies to an existing limited workforce, but by actually being able to take that autonomous decision with the device itself. So it was really about finding a specialty where there is this really big problem, but also one, and I think really importantly, one where outcomes are actually really good if you can catch skin cancer early. We know those mortality rates will be very, very high, sort of in the high 90s, if we can catch those cancers early. On the other end of the spectrum, if they're being picked up later, mortality is actually a genuine concern for the cohort of patients. And this is a condition that ultimately presents with a mark or a change in the skin that should be able to be detected. So we wanted to lean in and find those patients, make sure that the pathways that are currently struggling under the volume have a technology to support them to see, assess, triage, and get the right patients into the specialist's hands at the right time.
That is very interesting, and thanks for sharing that, especially seeing AI doing groundbreaking work on large scale problems is something that always makes us very proud. So moving on to the next question, we know specialist wait times are a major pain point. So can you share the scale of your impact? How many patients have already received faster diagnosis and care because of this technology?
Yeah, and these are numbers that we're really proud of, because I think we know that we're the first technology to get this class 3 clearance within a skin cancer pathway. We've had the technology deployed in the NHS since 2020, almost exactly 6 years ago. It was actually in the wake of that first COVID lockdown that we launched our first partnership. And over that 6 years, we've now seen more than 260,000 patients through these pathways and supported the identification of more than 20,000 skin cancers. I touched on sort of 1 in 4 consultant dermatologist posts being unfilled, an increasing gap in terms of referral numbers increasing year on year. And whilst within NHS England, people do focus on waiting times performance, we see organisations deliberately try and make sure that their cancer waiting times are performing as close or above target as possible. And that on the surface makes a lot of sense. And the way that organisations will try and go about staying on top of those pathways is often through additional clinics, additional insourcing or waitlist initiatives to bring in additional clinical capacity to try and stay on top of it, cancelling the routine referrals of patients that are waiting with eczema, psoriasis, other debilitating skin conditions. What we want to do is introduce a technology that actually creates a more sustainable option for those partners. It's an option that also doesn't mean that we have to pick and choose between, are we going to see those patients who have been referred on a cancer pathway, even though the majority fortunately will have a benign condition? Can we more evenly distribute the expert dermatologist capacity back to that routine waiting list? And the other reason why I think it's important that we consider that element here is we know that actually as many as 1 in 3 of those high-risk skin cancers, the melanoma and squamous cell carcinoma, are found on those routine backlogs. They're found not on the urgent suspected cancer referrals. And so what we want to make sure that we do is create pathways where if the initial triage, if that initial assessment may have triage may have missed a cancer, we're able to not introduce any additional delay in that patient being seen and actually expedite the rate of that routine review so that it can be found.
Wow. Did I hear you correctly? 260,000 patients that have
Yeah.
already been diagnosed and 20,000 cancers caught early?
Yeah, that's right. So that's more than 250,000 over the past 6 years, and actually as we bring on more NHS partners, we're sort of working with around 30 at the moment. As we bring on more partners, we're looking forward to that number increasing and us being able to offer in a sustainable way that additional capacity that hopefully supports that accessibility, make sure that patients are able to come through in a way that doesn't create additional burden for the healthcare system and really gives that dermatology department the slack and the tools to be able to see the patients who need them most, while being able to offer that earlier reassurance to those patients who we know the vast majority, we know that only 6% of patients who are referred as a suspected cancer will turn out to have a high-risk cancer. Let's give the rest of those patients that earlier reassurance that we were right to assess it, but it wasn't anything to worry about. Here's that good news that ultimately patients want to receive, which is you don't have skin cancer.
Right, right. Very interesting. And thanks a lot for sharing this. I think we've already dipped into this a bit, but how do you see this technology evolving to ensure that high quality skin cancer screening is available in underserved communities or regions with no access to specialists? I already understand it's a big problem and it's growing and it is being underserved, I guess, in most regions. So that's the first.
Yeah, and it's a really important point. I sort of in aggregate, the data suggests 1 in 4 consultant dermatologist posts are unfilled, but we know that distribution of dermatologists isn't equal or even. And while there may be some large teaching hospitals in the country who are very well staffed and don't have problems recruiting new dermatologists to their team, there are other parts of the country where they don't have any regular consultant dermatology support within the organisation. That also isn't just a picture. I think for a lot of the themes that we've spoken about with a UK centric lens, this is not a sort of a critique or a criticism of the healthcare system here. It is a similar picture around the world, and certainly the notion of dermatology deserts exists within the US healthcare system as well, where that ratio of expert specialist dermatology capacity just isn't evenly distributed. So by bringing along a technology like an artificial intelligence medical device, you're able to not only make that available in places where there may have been underserved communities historically, you're also able to do it with a technology that has a level of consistency that we can't expect from me and other sort of human clinicians. We know, and it's very, very well documented, how that clinician performance can vary based on what's happened recently. Has there been a missed case that's changing our behaviors and patterns, and we as a clinician overreact and start over investigating? Equally, is it just a time of day, or how hungry are you at the time of the assessment? None of those sort of human variables will apply to a technology like DERM that has gone through that evaluation, the clinical rigor, to show that actually you're getting a consistent and repeatable outcome from the device. And I think when we think of those underserved communities as well, it's important to approach it not only from an access perspective, but from an equity perspective. And historically, the data suggests that if a patient with a skin cancer has been under triaged in the current primary care step, that's more likely, it sort of disproportionately affects patients from older Asian and Black backgrounds. And so again, we have the opportunity with these technologies to implement a technology that has a higher detection rate, that's more likely to get the correct diagnosis at that initial triage, as opposed to the existing sort of standard of care pathway. And so I think we're really keen for those benefits to be understood, and the comparisons between actually the way that care has historically been delivered. How can we now implement these regulated, clinically validated technologies in a way that can really support the needs of the local communities and those patient populations, but also do it in a way that is immediately beneficial to the healthcare systems as well.
So currently you all are operating in all of the UK or in other European nations as well?
So yes, so we launched, and we've been working in across hospitals within NHS England since 2020. At the turn of last year, we was when we got that Class 3 CE clearance, and so that opened up the opportunity to work across other healthcare systems that accept and have the CE marking process as part of the regulatory landscape that they utilize. So since that came into place, we've deployed across 3 European countries. We've got deployments in 3 European countries, and more to follow in the sort of coming months ahead.
And I also hear a plan to expand into America.
Yeah, so I think we have always known that there are similarities in these healthcare systems, in these dermatology pathways, and fundamentally the ability to create a technology that gives additional capacity at that expert level is going to be useful in healthcare systems across the globe. We have deliberately lent into a regulatory process and ensuring that we will go through those necessary and important steps prior to deploying technologies in those settings. But the US and the FDA process is definitely something that we are working through.
Right. And this is obviously a very novel technology, and I'm sure the journey so far has been extremely exciting and daunting as well. So what is the single achievement you are most proud of regarding the improvement of patient outcomes?
The biggest one, I think, has to be getting. We've had a number of world firsts actually that I think we as a team are incredibly proud of. There are the rigor and the underpinning with first powered prospective clinical study looking at melanoma, getting that first autonomous CE marked Class 3 clearance. So those are the sort of the underpinning, but ultimately it has to come back to what is the impact that you're having within a patient journey and within a patient pathway. So being able to support that 250,000 patients and help identify those more than 20,000 skin cancers with a level of sensitivity above the level that's documented for dermatologists. That that level of performance not being, oh, here's a theoretical scientific experiment, but like here is real impact with real patients who have been through our pathways. I think that is something that we're really really proud of. And I think as my grandfather passed away from melanoma, so I think it's something that we, whilst the scale is the opportunity to show what you can do, it's really important as well that actually behind each of those patient interactions there is a patient and support network of people who enter these pathways worried about having a cancer diagnosis. And so the impact that we can have to support either a faster journey through that process, be it for reassurance and good news, or actually freeing up a bit more capacity in the system so that if they are having to go on to have treatment, actually we've done what we can to reduce delays. That's the really important part of what we do, and I think what we're very proud to have achieved.
That's definitely the one that even I'm the most proud of from this whole conversation, and I'm very happy that we are able to share these stories with rest of the world so that they also see how AI is positively impacting patient outcomes and is driving real change in the world outside of just experiments.
Exactly.
So thanks a lot, Dan, for taking out the time and joining us today. It was lovely having you here.
Not a problem. Yeah, thanks for hearing a bit about what we're getting up to.